All right. Well, welcome everybody. As part of the Global Child Health Lecture Series, we are delighted to have Dr. Nick Glomb and Dr. Carol Chen join us this morning. Well, good morning, good afternoon, good evening, depending on where in the world we are at this point in time. Carol and Nick are faculty at the University of California, San Francisco in the Department of Emergency Medicine. And both have been working primarily in Eastern Africa, or certainly Sub-Saharan Africa. Now thinking of education. So how do you train really all levels of care providers in pediatric emergency rooms and pediatric urgent care settings to ensure that they all feel comfortable in caring for children who are coming in with really walking in the door with any type of disease. I think I'll keep the introduction fairly short so we can jump in and hopefully have a great conversation. So thank you so much, Carol and Nick.
Great, thanks a lot. Hi, everybody. Great to see everyone here today, and thanks for inviting us to come and speak with you. So hope we have a rich presentation and discussion today. And Carol, Chen, and I will be talking about developing medical education projects in low resource settings. Both Carol and I are faculty at University of California, San Francisco. We're both associate professors in pediatric emergency medicine and our global health affiliate faculty at UCSF. We're also part of the PAHO or WHO Collaborating Center for Emergency Critical Care and Operative Care. So we have no conflicts of, we can go to the next slide, sorry. We have no conflicts of interest at all, and funding for the projects that we're going to discuss today, the Botswana project, we'd like to acknowledge assistance and support from Texas Children's Hospital, Baylor College of Medicine in Houston, Texas, and also support from the Botswana Ministry of Health and Department of Emergency Medicine at Princess Marina Hospital, which is the main referral hospital in Gaborone, Botswana. And for Carol's work, I would like to acknowledge the Hellman Foundation and the Doris Duke Fund. We can go to the next slide. So our goals and objectives today. For goals, we'd like to discuss the general principles of curriculum development, and then relate curriculum development to medical education, and specifically to two different projects that are related to EMS work in Botswana and African Federation for Emergency Medicine work in Tanzania and Liberia. And then we'll discuss factors influencing global health work and offer some thoughts about building a career in global health. In regards to our objectives, we're going to list the general steps to curriculum development, basically how you approach developing a curriculum for medical education, and then list considerations specific to medical education and curriculum development, and then describe the importance of developing bidirectional relationships. We can go to the next slide. So before we go on further, we'll just give just wanted to pause and just give a little bit of background about how each of us got into global health. Carol, you can go ahead first.
Great, thanks, Nick. Yeah, so as you mentioned, I'm Carol Chen, and so the two. Really great to be here with you guys today. How I sort of ended up in global health, I kind of took a circuitous route, as you'll see Nick kind of did too, but like we both, I feel like, had careers before this. But no, I did a pediatrics residency, and afterwards I actually worked for a while before going to fellowship. And so I worked abroad because for personal reasons, we had to move abroad. And so I ended up in Hong Kong, and then I worked all over Asia for various different groups, including MSF or Doctors Without Borders, International SOS, and so forth. So I really developed a sort of interest in global health and serving populations in low resource settings. And that kind of led me to do the fellowship in pediatric emergency medicine, as well as global health at Texas Children's, which Nick and I did together. And yeah, and then from there, after I joined UCSF, became really involved with AFEM, as you'll find out a bit more about, the African Federation for Emergency Medicine, as well as our WHO Collaborating Center that Nick had already mentioned.
Great. Thanks, Carol. And yeah, as Carol mentioned, I too have had a circuitous route to global health and where I am today. I actually was a business major in undergrad, studied marketing and advertising, and then ended up during my time in undergrad, worked with Habitat for Humanity abroad. And that was really my first foray into the global scene. I worked in Ghana. And at that point, I decided, I knew I wanted to go into some type of global work, but had not yet identified global health as my focus. And then after a short stint in advertising, I decided to go join the Peace Corps, and then Peace Corps ended up, I worked in Mauritania, West Africa, and did a lot of health education where I met a lot of physicians that were working in global health or public health. And I thought, hey, this is like something I might be interested in doing. So I ended up going back to school, took all my prereqs, and then ended up going to medical school. And in medical school, I did the Albert Schweitzer Fellowship in Gabon, in Limbourg, Gabon. If there are any of you, if there are any medical students that are happen to be French speaking or interested in global health experiences, I encourage you to take a look at the Albert Schweitzer Fellowship. It was it's a 3-month experience where you work in Gabon, and was really a phenomenal experience for me. And then after medical school, in residency, I worked at the same hospital that Carol worked at, or is currently working at, in Tanzania, Muhimbili in Dar es Salaam. I worked there during my 2nd and 3rd year as a pediatric resident, and then went into pediatric emergency medicine and global health fellowship with Carol at Texas Children's, that she had mentioned. And there worked in Botswana, and I'll be talking about the Botswana project today. And then more recently, I've been working in Uganda, working on development of an emergency medicine residency training program in Kampala. All right, so let's go ahead. We can go to next slide. Great. So we're going to start off first talking about the Botswana EMS project. So EMS, pre-hospital, I'm going to kind of use those interchangeably throughout the presentation today. But as background for the Botswana project, the public pre-hospital system in Botswana really began in June of 2012 in response to the Botswana Ministries of Health concerns regarding potentially preventable morbidity and mortality. Especially, they have a crazy high number of road traffic accidents or car accidents throughout the country. There's one main highway that bisects the country north to south, and there are just a lot of car accidents and a lot of morbidity and mortality related to traumas. So at the time that I started working there in 2013, the Botswana Ministry of Health had opened up 8 different emergency medical services centers throughout the country. They now have more than 15, and then have combined, at the time, they have combined of approximately 150 providers that were serving a population of just over 2 million, and that's throughout the whole country of Botswana. The Ministry of Health at that time had identified significant deficiencies in the pre-hospital workers' basic resuscitation skills, specifically as it pertains to care for pediatric patients. You can go to the next slide. So through an ongoing collaborative between the Princess Marina Hospital, which is the main referral hospital, as I said, in Botswana, in the capital city of Gaborone, and the Texas Children's Hospital, where I did, as I mentioned, where I did PEM and Global Health Fellowship, my emergency medicine colleagues and I formed a relationship with the Ministry of Health EMS Director, Major Lava, who requested from our team help in developing a training program for his EMS providers. At the time, the Botswana President Kama had appointed Major Lava to become the director of the Botswana Ministry of Health EMS program. And really, he was the first trained paramedic in country after Botswana Ministry of Health had actually sent him to Australia for training back in 2012. Just as a little background on Major Lava, he's just an incredibly dedicated and passionate about his position in the Ministry of Health, and really deeply invested in making the EMS program succeed. He unfortunately had a personal tragedy related to EMS, where his youngest daughter, who had a history of asthma, had a severe asthma attack. And at the time, this is back in 2008, there were no EMS services available in the country to assist her. And unfortunately, he couldn't get his daughter to the care she needed in time, and she passed away. So really at that point in time, Boucher really, or Major Lava, devoted his efforts to make sure that this situation would not continue. So these are just some photos with some of the Botswana EMS training team. Major Lava is in the photo to the right with the blue button-down shirt. All right, and now Carol's going to give some background on her work with the curriculum development.
Yeah. So a little bit of background to get you guys oriented. So I just show this map. This is actually from an old paper from 2017 to look at where formal emergency medicine training programs currently exist on the African continent. And it does not reflect, there's one in Mozambique currently. So that's not in there. And then the other thing it doesn't really reflect, because there's only really one sort of combined pediatric emergency medicine and critical care training program existing right now in Kenya. And so in terms of like really pediatric EM specific training programs on the continent, they're pretty limited. Although, good news, there's a lot actually in development. Nick and I are both working on one in Tanzania is looking to develop one. Uganda, I think, has interest. It sounds like Rwanda as well. So I think there's a lot more exciting news to come on that. Why it's important, I think, because, I think we see as EM, general EM sort of encompassing all, including the pediatric EM side, which it does. But I think the reason to be concerned or to care more about, really more pediatric specific care is just if you look at, the population pyramids for sub-Saharan Africa, a lot of it is pretty focused in the younger age groups. So really those under age 18 years are going to make up a larger part of the ill and injured that you're going to see. And children comprise about 30% of African emergency department visits, according to the WHO, and child mortality is highest in kids less than 5 years old. So that's why it's really, I think, moving towards focusing a bit more on the pediatric population is really important. So a little background on AFEM for those of you who are not familiar with it. As I mentioned before, it stands for the African Federation for Emergency Medicine. It's this huge professional organization. It has probably well over 2,000 practitioners across the continent that practice emergency care. And as I showed in that map, emergency medicine is not a recognized specialty in a lot of places. And so part of what they do is they really try to support the development and advancement of emergency care in a lot of these countries. And that's through leadership development, advocacy. So a lot of times they provide resources for people to be able to advocate for with their own local ministries of health to try to develop emergency medicine systems and training programs. There's a lot of collaboration, research, and education and training that goes on. And for those of you who have seen the AFEM website, they actually do also provide, there's a lot of curricula that have been developed and they sort of are published for free and open access use. And they also try to do a lot of work with policies and frameworks. And I had sort of joined AFEM in sort of their education realm. And I was helping to develop educational curricula that they had requested. And one of the requests that came years ago around 2016 was around developing a pediatric specific curriculum to help, again, focus on really training providers to be more proficient in pediatric specific care. And so through that, we developed sort of a multi-institutional group of PEM and local health experts, because obviously PEM doesn't necessarily exist in a lot of countries on the African continent, but pulling together a lot of the pediatric and EM expertise that already existed to develop this curriculum. Okay, so Nick's going to talk next about sort of what we used as a model.
Great, thanks, Carol. So in order to develop any education curriculum, it's really recommended just to take a really systematic approach to ensure that both the local needs are met as they differ based on, these local needs are going to really differ based on the population that you're serving and the needs of the learners. So Carol and I are we both used Curran's model for curriculum development to develop our projects. And I'm just going to walk you through the different steps of that in case you haven't taken a look at that or seen that before. So the first step is on the top, and that's really the identification of the problem. What's the issue at hand? What do they need training for? And then what you need to do is basically go through a needs assessment of the targeted learners, and then followed by addressing or developing goals and objectives, and then identifying step 4, your educational strategies, and then you follow through with the implementation of whatever the training program or curriculum that it is that you've developed. And then really crucial to get the evaluation and feedback at the end, just to make sure that you are on point, and to see what changes you have to make to the curriculum to make sure you're meeting your goals and objectives. So throughout the rest of the presentation, we'll share some examples of how we did this for our respective training programs, really with the intent of guiding you through how you can likewise develop a curriculum in other countries or other settings, wherever you may be practicing in the future. You can go to the next slide. So as I said, the first step beyond the identification of the problem. So for me, the identification of the problem, when I was in Botswana, I spent a lot of time just meeting with different healthcare professionals in Haberene, in the capital, trying to understand the environment and what some of the challenges were. And as I had mentioned in the background section, it was Major Laba from the pre-hospital program. When I met with him, he really had identified the problem, and that problem was a deficiency in training of or lack of training of the pre-hospital providers in Botswana. So the next step after you identify that problem is really the needs assessment. And the key points of the needs assessment are really to look specifically at your group of learners, really understand the learner's background and any existing gaps in knowledge, to identify the existing resources, and really who are the key stakeholders that you're going to be working with. As I mentioned, for the Botswana project, this was not just an issue of the lack of training, but there was questions on the availability of staff and ambulances. We had to take a look deeply into what equipment is available and reliable for use for the EMS teams. And really, there's no use in training, for example, there's no use in training the EMS staff how to intubate if there are no ventilators in the country, which at the time in 2012 was the case. Regarding your assessment and identifying the stakeholders, I really can't stress this enough, and the importance of working with these stakeholders and identifying really, it's super important to identify a local champion for whatever project that you're going to work on. And I think in the long term, this is going to serve you and the project incredibly well, as these individuals really understand the intricacies of working in that specific environment. And also helps to reduce yourself as a provider imposing your biases on the project, and really helps ensure that project goals align appropriately. And so, the next other important points, as far as like doing the needs assessment, you really need to assess the prior knowledge, the experience and training of your audience, and then certainly analysis of the data and setting priorities for any future actions. So you can really accomplish the above, or this needs assessment, through a mix of, you can do surveys, focus groups, in-depth interviews with your learners, and really it's important to understand the different demographics of the particular population that you're working with. We can go to the next slide. So for the Botswana project, for our needs assessment, so as I said, we assessed the educational needs of the pre-hospital providers in the Botswana Ministry of Health EMS system. And we did this by reviewing EMS response calls for the Botswana EMS system, and then analyzing trends in common response calls for both pediatric and adult patients, because we were looking to potentially develop both pediatric and adult curriculums, and then identify potential skills required for the EMS providers that are responding to different medical calls throughout the country. You can go next slide. So we started off by doing a survey of the providers and held focus group interviews of Botswana EMS providers. And really, we did this just to identify existing gaps in knowledge and skills, opportunities for additional training. And this was incredibly critical as the Ministry of Health EMS only started, as I mentioned, they only started just a year and a half before we did this needs assessment. And the pre-hospital team at that point in time primarily consisted of nurses and medical technicians that were basically the Ministry of Health just reassigned nurses and medical technicians from different areas of the Ministry of Health and then reassigned them to pre-hospital or EMS work. So they had absolutely no background or any true pre-hospital experience before working with the Ministry of Health EMS program. For our data analysis and demographic investigation, we took a convenient sample from 12 months. That was at the time, it was January to December 2014 of Ministry of Health EMS response calls. And that was taken from the main EMS logbooks that was provided to us by the Ministry of Health. When looking at those logbooks, we analyzed the age of the patient, the sex of the patient, time of call, chief complaint, secondary chief complaint, and then the priority or acuity level, where the patient was delivered to, and whether it was a call out or a transfer call from hospital to hospital. And then we did a chi-square test to analyze this categorical data. We can go to the next slide. So these are the results of the most common EMS chief complaints for the pediatric and adult response calls. And then, so we took this information and based on the available equipment that the EMS providers had access to, we then identified applicable skills trainings that would be needed to carry out or to care for these types of response calls. And some of the skills we felt would be helpful and were identified as desired for additional training. And, we placed on hold, and they did, especially if they didn't have the needed equipment to reliably carry out these tasks, as I mentioned, like intubating, because they don't have ventilators, we kind of put those on hold or put them in the background, and hopefully we'll address those in the future. All right, so now Carol will share her experience with the needs assessment that she and her team conducted.
So similarly, we looked at a lot of different variables to try to figure out what would we want to include our working group in terms of including what we want to target in our curriculum when we develop it. So we did sort of like Nick mentioned, we did a lot of interviews and focus groups, which we considered like qualitative data around. And for example, here's some of the results. I'm not going to show all of them, but sort of like what kind of topics do you think should be included? And then our quantitative data was pulling like actual hospital records, similar to what he mentioned of looking at what are the diagnoses that we're seeing in kids that are presenting to the emergency department. And this particular needs assessment was done in Tanzania because we were going to pilot it. We had a lot of our partners in Tanzania at Muhimbili National Hospital were able to accommodate the pilot at the time. And so we were, that's kind of where we conducted our initial needs assessment. As you can see, there was actually quite a bit of overlap. 8 of the top 15 diagnoses from our quantitative data, meaning all the chart reviews, actually were shared with what people were saying was the most important things for them to learn. So that was kind of cool. And then these were some themes that came out of the interviews and focus groups that we did to try to figure out how do we what else do we need to consider? All the things that Nick was kind of talking about earlier, what are sort of the things we need to consider when we think about teaching this curriculum, right? Like what happens at the beginning of someone coming to care? Why might their presentation be delayed? What are some issues with the care they get in the ED? And can tie into things like, like maybe they have a lack of supplies, they have a lack of staffing, they have a lack of space. And then what happens to someone after they leave the ED? Let's say they got the optimal best care that they could potentially get in the ED, but then they have to go somewhere else from there. And so what are the considerations that you need to think about, including when you teach this curriculum, to say, okay, we need to consider that they're not going to stay in the ED forever.
Great. So the next step in the curriculum or developing a curriculum is really identifying your goals and objectives. So it's important to note that when you're developing your objectives, you should be thinking or asking yourself, what is it that you want the participant to be able to do, or what information do you want them to walk away with? And so your goals need to be general, they need to relate to the curriculum itself, and then certainly you have to address what knowledge and understanding are you looking to attain with your curriculum. Regarding the objectives are specific and they relate to the learner. They're measurable, they're demonstratable behaviors, and really we use the SMART mnemonic that really brings structure and trackability to the goals and objectives that are developed. And so your objectives should be specific, measurable, action-oriented, realistic, and time framed. And of course, your goals and objectives should be linked together. You go to the next slide. All right. So this is just an example of how we develop goals and objectives for the Botswana project. So we utilized the framework that we've talked about to develop learning objectives for the Botswana EMS course. And so this is one of the prioritized needs, and that was to enhance skills in newborn resuscitation for the Botswana program. And for each learning objective, we develop cognitive, technical, and behavioral objectives. So these are just some examples of each for the neonatal resuscitation training. We can go to the next slide. So as far as your educational strategies, which is the next step in curriculum development, you just have to decide how you want to teach this material. So you need to develop a detailed plan of instructional methods that will best achieve the goals and objectives as set out by the team. So simulation is one possibility for an instructional method with multiple different simulation modalities that are available. So for our Botswana project, we did decide on simulation as the main education modality, mainly because this offers the healthcare providers, the EMS workers, really an effective way of developing clinical knowledge, their procedural skills, teamwork, and communication. We can go to the next slide. So these are just some photos of the hands-on skill stations. And we really did a mix of simulation training, task trainers or hand-on skill stations, and then just a few didactic lectures. We really wanted to limit it how much time we were just talking at the providers. I wanted it to be more interactive. We can go to the next slide. So once we decided on simulation, we chose the specific type of simulation training. As some of you that have been involved, or probably all of you involved in simulation training in the past, there are many different modalities. There's high fidelity, low fidelity, task trainers, simulated patients, and virtual reality. Knowing the technology that we had access to and the different equipment that we had access to, we decided on low fidelity simulation and task trainers. And so the Texas Children Education Grant really helped to fund the equipment. So the simulation mannequins, skills training equipment for this training program. We can go to the next slide. So there are a few different ways to conduct simulation training. Also, there's the feedback and debriefing, there's a deliberate practice, and then mastery learning. And We decided to use rapid cycle deliberate practice. So allow the teams to go through different scenarios. We stop them when there's a major point to be made, and then we have the teams reset and then go through and kind of master the scenario before, as they go through and progress. You can go to the next slide. Regarding the implementation of the, which is the next step in the curriculum development process, I can't stress enough the importance of having political support for the curriculum. And this means that it just means that you are not developing, make sure you're not developing your curriculum in a siloed fashion. So collaborate with the Ministry of Health, collaborate with the hospitals, whatever organizations that you're working with, making sure that your key stakeholders are involved. Make sure you develop relationships and understand the different systems and processes in the specific environment you're working on. With implementation, it's really important that you, as I mentioned before, you identify and procure all the required resources. You address any barriers to implementation of your project. And then you pilot the curriculum, and certainly important to do a train the trainers, making sure you're allowing for sustainability of your project. So it's not you yourself that are training the team, it's actually your key stakeholders who have been trained and are training the targeted audience. And then you go ahead and implement or hold the training and then refine your curriculum over successive cycles. You can go to the next slide. So we started off by conducting trainings throughout the country in 3 main Ministry of Health EMS centers. And we did this, as I said, we did the Train the Trainers course, and with the idea this is going to help with sustainability and carrying this on long term. And the large group trainings that we did for the sim training were just 2-day trainings with a mix of lectures, as I said, sim scenarios, skill stations, and then final testing sessions where we would evaluate the learning of the providers that participated. We can go to the next slide. And as you develop your curriculum, one of the final steps is the evaluation and feedback. So as you're developing the curriculum, it's really essential to begin thinking about the evaluation process early on and how you're going to measure your successes. So this is one example of how you can evaluate a curriculum. This is Kirkpatrick's model, and it basically describes 4 different levels to evaluate training programs. The 4 levels are, the first level is just reaction. This is like a really simple, you do this via self-assessment, and you're asking basically, or you're assessing whether or not the trainees got what they wanted out of the course. The next level is going to be your learning. So this is assessed via pre and post tests. And so these are written, or they can be simulation pre and post tests, which is what we did for our project. And then behavior, they have, basically assessing whether or not they've been able to apply what they've learned. And then the top, the number 4 level is going to be results. And this is really by far the most challenging to attain. And this is really asking, for this project, have we been able to affect morbidity and mortality? You can go to the next slide. So when looking at provider confidence and the level of pre and post training for our sim training, we noticed an overall improvement of 15.5%. You can go to the next slide. And then for the pediatric content, when comparing pre and post simulation scenarios, we found an average change of 21%. And for the written test, we saw an average improvement of 10%. You can go to the next slide. For the adult content, when comparing pre and post simulation test scenarios, we found an average change of 33%, and with the written test, we saw an average improvement of 18%. So our plan for evaluating, whether or not there was any practice change or behavior change, we basically took a look at the EMS. They have physical, what are called patient report forms. They're paper forms that are filled out on every single response call. And we basically took a look at those patient report forms pre and post training to see if the providers were actually following through with different skills and knowledge that they had been taught during the training itself. We can go to the next slide. So we reviewed approximately 350 response call forms from 6 months prior to the training and 6 months after. We had 21, there were 21 separate actions that were evaluated as seen here on the slide. You can go to the next slide. And so we found overall they had an improvement in 9 of the 21 actions with significant improvement in actually just taking vital signs. Sounds simple, but there was improvement there. They had improvement in documenting past medical history, improvement in their treatment actions as shown on the chart. And then for the initial assessment, there was really no significant changes. All their actions, like doing their airway, breathing, circulation assessment, had greater than 98% completion pre and post. You can go to the next slide. So the limitations for behavior change evaluation, really there are multiple team members for the Botswana call that were on response calls, and it's possible that EMS provider who was trained was not the one that was actually documenting. And then in July 2016, we also had the Ministry of Health started using a new patient report form. And so to correct for this, we compared the 2 report forms and only collected data that was presented on both forms. We can go to the next slide. So in conclusion for the simulation training, we feel confident that providers had an increase in confidence in the management of common pediatric and adult presentations. They felt they did improve provider knowledge base. We may have influenced an improvement in pre-hospital provider care, and the training was associated with enhanced compliance with documentation of pre-hospital actions. I think the opportunities for us are really to focus on our areas of weakness that were identified in the training, investigate why some procedures were not performed, and really expand the training curriculum. We can go to the next slide. And then as far as our lessons learned, certainly, developing an educational curriculum takes time. So just a tip to everyone is don't take shortcuts. It really takes time to develop these relationships and develop the curriculum itself. Again, I can't stress enough of the importance of defining the needs of the learners. Simulation is an excellent hands-on approach to teaching. I feel like it's very effective. And the teaching really needs to be conducted primarily by your local champions, not by you, the global health expert or worker coming in. And again, you need to evaluate curriculum and really develop a way to figure out how you need to pivot or change your curriculum if needed. And then I'll always utilize technology that's appropriate for the setting that you're working in. As far as our next steps, we can go to next slide. We're looking at continuing to expand the simulation curriculum, looking for funding for additional simulation equipment because there's a lot of wear and tear on that equipment. And then currently looking to develop a community-based EMS program. All right, Carol, you can go ahead.
Great. All right. So I'm going to talk about some of the similar steps, not quite all of them, but similar steps with our pilot to kind of give you a flavor of how some things were similar and some things were different. So just to give you a little background, when the group was assembled by AFEM to create this curriculum, we did recognize that, there are different levels of providers that see kids, all the way from nurses to, in some settings in Africa, they do have pre-hospital systems. And so all the way up through, through our physicians and even specialists. And so how do we create a curriculum for everyone? We decided we couldn't, so we were going to create different types of what we call tiers of curriculum. And so our tier 1 curriculum is really targeted towards our pre-hospital and our nursing providers. And so that was created first because obviously that was a larger swath of the population that we could reach through this, that AFIM could reach through this curriculum. And we, as I mentioned earlier, we had partners in Tanzania and Muhimbili National Hospital that had been part of creating the curriculum that were, and so therefore could teach it. As Nick mentioned, really important to have your local partners there. So we piloted it there. And so we conducted over 2.5 days of training in the ED there in Dar es Salaam. We had about 15 nurses participate. We had controls to match them to, and the training consisted of lecture, skill sessions, and simulation scenarios. And then in terms of evaluation and feedback, we use similar sort of levels as Nick was talking about, the Kirkpatrick levels. So for the first level, looking at self-efficacy surveys, pre and post, and also our control group versus our experimental group. And then knowledge, we actually use knowledge tests. So they were written multiple choice tests, pre and post. And then critical actions during observed resuscitations was kind of our way of trying to get a sense of, are people actually doing what they're being taught to do? Due to sort of some IRB complications and whatnot, we were only able to look at post. So we compared matched versus control group participants post and we didn't have any pre-data to compare it to. And then we also did some interviews of participants to kind of see how the training went. So here's just some photos to show you guys. On the right, this was our lecture, obviously style teaching, and you can see at the front, Kalalo and Gemma is our instructor. She's one of, she was completed the emergency medicine residency training program in Tanzania at Muhimbili. And then on the left here, this was some of the skills stations and simulated scenarios that were part of the training. And Raya Yusuf, you can see here on the right with the papers in her hand, is the instructor. She's actually now the head of the pediatric emergency department at Muhimbili. So some results, I'll go through this quickly just for time's sake, but when you look at self-efficacy, we had people rate themselves across, we asked them a lot of questions. How comfortable do you feel performing X action? And then it had to relate to whatever we trained them to do with addressing pediatric illness and injuries. And they would answer on a Likert scale. And then we would ask them, least comfortable to most comfortable. And then we had, like I mentioned, control and intervention groups and pre and post. And basically all this is kind of showing that there's a significant difference. Obviously, there's no difference between the control intervention groups at the beginning, but afterwards there definitely is, that you can see that the intervention group was a lot more comfortable with the actions afterwards. And then here you can see if you compare across time points. So same for the knowledge test, the multiple choice test that we gave. We did see a significant difference both pre and post in the intervention group when you compare to the controls. And that's all this is showing here. Interestingly, it was a little more challenging with behavior. So as I mentioned, we weren't able to collect the data pre, but we were able to collect data after we held the pilot training. So basically we had Muhimbili, we hired research assistants there who would go and just observe pediatric resuscitations in the ED. And then that involved either our intervention nurses or our control nurses. And then they had checklists. Our RAs had, our research assistants had checklists, and they would basically say whether these people performed these critical actions or not. And they observed 3 different types of pediatric resuscitations: septic shock, trauma, and respiratory distress. And as I mentioned, only post. And really, we only saw a significant difference in a few, like well, here's an example. It's more than 3, but there's only a few of the actions. I would say the vast majority of our critical actions, we did not see a significant difference between the control and the intervention group. So that was something we had to kind of chew on afterwards to try to figure out some of the things I think were And this was a lesson learned too, is just the situation. So like, for example, some of it was recognizing that a child was in respiratory distress in the way that we would, you know, or a child was in septic shock. And one way that we would, the only way the research assistant could recognize that was if the person said it out loud. But, you know, in a real resuscitation, that may not be something that someone actually says out loud. So that may have gotten missed, for example. So those are kinds of the things that you have to think about when you're kind of, if you're going to do a project like this and kind of think about, okay, how am I going to evaluate? You need to think through, you know, maybe this could be a complication for why we don't see what we hope to see or hope to prove. So, and that's also why the pilot's really helpful, because this is your chance to kind of just run through it and see what really worked and what really didn't work before you try to launch something on a larger scale. So the tier 2 curriculum we created was targeted more towards our physician groups working on the African continent, mostly sub-Saharan, but all over. And so we developed our next step after the tier 1 pilot was to, or sort of in concert with, we were developing a tier 2 curriculum for the targeted towards the physician group. And when we did finish completing that, we decided we had partners in Liberia at JFK Medical Center in Monrovia that had helped with creating the curriculum, and were able to arrange for a pilot there, which was kind of nice because I think we wanted some geographic variability with the pilots as well. So we moved, so that gave us a little bit of West Africa exposure. The Ministry of Health wanted to train all of their interns across the country. So we ended up doing sort of 3 trainings, each over 2 days over a 1-week period, so that we could rotate groups through to reach all the intern groups across the country. And then we were also able, they do have pediatric residents at JFK, so we included them as well. We did not have controls. That was a control group. That was a request by the ministry. So we only had the intervention group. Similarly, you can see the training composed of similar components. And again, same type of evaluation. We were trying to keep it pretty standard. Here's just some photos showing some of the trainings that were done. It's funny, you know, we had planned for, like, similarly to Nick, we had planned for these lo-fi simulations with like mannequins and stuff, but actually they enjoyed doing it on each other more. So that's why you can see they were taking turns kind of lying on the table and simulating on each other. They found that to be more helpful. All right, so if you look at the results, I won't show you all the tables like I did before, but it was very similar when we did this in Liberia with the tier 2 curriculum. We had improvements of self-efficacy as well as knowledge. And again, this was only in the intervention group. You know, we didn't see any significant, again, not a lot of significant changes in the critical actions. And I just want to point out, for both groups in Liberia and in Tanzania, these were observations that were done immediately after the training. So it's a time period where you would think if you were going to see a change, you would see it because it's kind of fresh in someone's mind. And then, oh yeah, we wanted to collect some 48-hour mortality data, but that just wasn't possible given the setting. Right, and so I'll hand it back to Nick to talk about the next sort of part, a very important part of doing this kind of work, which is dissemination.
Yeah, it's important, and not you know, not to promote yourself, but really important to be able to share the information that you have developed with the curriculum. So not only sharing the curriculum, but sharing how you did the needs assessment, how you you know, how your Kirkpatrick level assessments panned out, and really being transparent and showing whether, you know, whether or not the training was effective. And the idea in developing, you know, in disseminating this information and your curriculum is that hopefully the curriculum can be used as a model or a foundation for other countries or other programs to utilize this, you know, in similar type settings, and they can just adapt it for use for their specific program. You go to the next slide.
Yep, and this is just showing, again, on our side, the dissemination. So if any of you are interested, the Tier 1 curriculum is published on the AFEM website. You can, it's freely and publicly available for download. So you can, it's just, if you just Google African Federation for Emergency Medicine. The Tier 2 curriculum is currently under, we did peer review already, and now we're doing one last, it's called expert review, and then that should be published as well. So those are available. And then like, and as Nick mentioned, I think we published our work as well in Western Journal of Emergency Medicine. I think that's important to have that component so other people can learn from it. Okay, and then yeah, I just wanted to offer a few reflections from our group in case they're helpful as you think through your potential medical education projects. So we kind of, after we did Tier 2 pilot, we were sort of like, okay, you know, where are we and how does this match with our mandate? What have we learned and where do we want to go? And I think originally we had planned to do a Tier 3 curriculum, which would be really subspecialized. So this is for specialist physicians already existing, like say if you have emergency medicine physicians or pediatricians, would they want to do more of like a fellowship level training? And I think at the time we decided that those were so few and far between for our target audience that we would not do that at first. And then the other thing, of course, as I mentioned before, is why are we not necessarily seeing the change in behavior? Our trainers continued to train as after we left, the trainers that we had trained at the time. And so we don't have a lot of data. We have some follow-up data on that, but obviously the pandemic got in the way. So we're also continuing, our AFEM group is continuing to look at, we're doing more interviews with healthcare workers in Africa. And actually we recruited another group of healthcare workers in different parts of Africa to help us do these interviews to find out what exactly is it like in the implementation step that we may be missing to help people really use, you know, change behaviors. I think not necessarily use the curriculum because they are, but maybe change the behaviors going forward. And then last couple slides, just want to talk a bit about bidirectional partnerships, which we have a bit, but just again, why these are so important. And I think one thing, those of us who work in high resource settings, sometimes we forget that low resource is not just about, you know, supplies and whatnot, but it not physical resources, but it also refers to human resources. You know, our counterparts are often working many jobs at one time. And so I think recognizing that as well is really important. I wanted to just show you guys, this is Dr. Upendo George. She was one of the first female emergency medicine physicians in Tanzania. She was the head of the pediatric emergency department at Muhimbili, which is the country's, as I mentioned, the country's national referral hospital. She was a really good friend and colleague for me and Nick, and she and I worked really closely together on this AFEM curriculum for over 3 years. And she was the reason that we were able to push this forward in terms of doing the pilot there. And she was actually supposed to be the lead instructor rather than Kilalo, who you saw in the photos, but she got pulled away by hospital leadership during the time. And I think because you know, she got pulled away to do like another project that the hospital had asked at the time that we did the pilot. So again, just showing you that our partners oftentimes have a lot going on. And so just recognizing that and trying to be respectful of that is really important, and being flexible. Yeah, Dr. George, unfortunately, she passed away pretty suddenly and unexpectedly during the pandemic. So it was really tough, I think, for the group there as well as all the rest of us. But her legacy definitely lives on. And as I mentioned, Raya has taken over the pediatric emergency department there, is continuing on that work. And then I think just a couple more notes. So I think a lot of times when we get really excited about a project, you know, and we kind of have in our minds what we would like to do, I think stopping to say, how does this align with the priorities of our partners so that it makes sure it benefits both sides? I can't say enough about that because, you know, it's hard. I think it's tricky because a lot of times people want to be polite and say, yes, I want to get onto your project when maybe they just don't have the time, or maybe it's not truly a priority for them or their group or their hospital. And I think power dynamics can definitely prevent people from feeling empowered to be honest with you. So I think really trying to, and I think a lot of what Nick said about making sure if you spend time developing relationships, that really helps with trying to say, okay, empowering your partners to feel honest with, that they can be honest with you. And then plan ahead, but stay flexible. And then finally, just recognizing your privilege. For those of us who do work in high resource settings, recognize your privilege, use your superpowers to advocate for your partners. And then that can be maybe just access. I took a couple of, you may have noticed, I took a couple of pediatric residents with me when I did the training in Tanzania. And then also just including, it's your responsibility to include your partners as authors on anything that you produce or publish. And then also just supporting their local resources. So, the grant money that we obtained, we both, instead of bringing in your own, say, research team to collect data or analyze the data or any of that, it's really investing in local teams to do it instead, so that you're supporting their research infrastructure and resources. Did you have anything to add to that, Nick?
No, again, I would just emphasize the investment in time before you, or as you're developing the curriculum. I just can't emphasize that enough, really developing the relationships, as you said. And then, as you said, following that structured approach to curriculum development.
And then just lastly, sorry, I know we only are giving a couple minutes for questions or comments, is I wanted to offer some thoughts we had around building a career. So I had just two things to say: be there and do it. So being there, meaning there's so many global health communities. For those of you practicing in the US or other high resource settings, networking is really important. All the different places I've mentioned, all the different acronyms there. And doing it, meaning just find a global health mentor, get your hands dirty, get into really build and invest in relationships, not just projects, but relationships with people. And then finally, if you're going to sign up for a project with someone, make sure you do what you say you're going to do. I think that follow through is really important, not just for the project, but again, for sort of building that relationship long term. All right, I think that's all we had. Any questions or comments?
Thank you so much, Carol and Nick. Really appreciate the work and the thoughtfulness of and considerations you elaborated upon in terms of the approach itself. As mentioned, the floor is open. Feel free to ask any questions to our presenters. You can put comments in the chat, or you can just unmute yourself if you'd like. And I'll be putting in an evaluation survey into the chat here. Maybe I'll start with one, and it looks like timing wise, we just have maybe a minute or two. But you talked a little bit about bidirectionality and the lessons learned. And on that vein, but a little bit more, I guess, on the topic of cross-pollination, how has this approach to thinking through curriculum development and evaluation impacted your assessment of trainees here in the US? Both of you are medical educators here in the pediatric emergency room at UCSF. How has this approach to influence your thoughts of trainees here with that global health mentality?
Yeah, I think a lot of it, certainly going through this curriculum development type project, understanding your learners, understanding where your learners are coming from, understanding and appreciating that people are coming from different backgrounds, people are having different experiences, different reasons why they went into medicine, and so I think that all affects who you are, who each of us are as a physician or healthcare provider, whether it be a nurse, a PA, and so I think really, as much as you can, taking the time. I always, I don't mean it to be like super casual, but when I work with my medical learners, I want to get to know them as much as I can, understand a little bit about where they're coming from. And I think that just helps in developing relationships. In the emergency department, it's a little bit difficult because they tend to be very quick relationships. It's like you're only there for a shift, or you're there for 2 weeks, and then you move on. But I think as much as you can, taking that time to understand who the learner is and where they're coming from.
Yeah, I just want to echo everything that Nick said. And I think you bring up a good point too, Sohail, around like evaluation, like how we evaluate our learners and what we think about. And I think sometimes maybe the way we think we're evaluating them isn't necessarily getting us what, truly what the output that we think we're getting. And so I think delving into that a little more, there are reasons we use multiple choice tests or whatever. On a shift, obviously it's different because it's a lot of face-to-face contact. And I think for us, being able to take advantage of that, and just, to talk about, okay, what did you learn and how did it look? And tell me why you're thinking that versus this. And I think that could be, sometimes it allows us a little bit more reflection on why we think somebody knows or doesn't know something, which may or may not be the case.
Thanks. Yeah, I see a question in the chat from Michaela. Greetings from rural Malawi.
Yeah, they're asking about wanting to implement
Malawi. Would
simulation
love
training.
to implement some of that simulation here. Do you have any recommendations for simulation training? And does UCSF have any opportunities to collaborate?
Yeah, so as far as the simulation training and limited resources, as Carol demonstrated with, I think it was the Liberia program, I mean, you can use people, you can use towels, you can use, as far as the mannequin. So you do not need bells and whistles. You don't need the high fidelity sim mannequins. You can really get a lot out of just kind of jerry rigging mannequins, and even training sessions. Certainly, you can make different task trainers out of available resources. So sometimes you just have to get a little bit creative. And then the main thing is never the mannequin itself. That's not the thing that really people are coming away with, like, wow, like I had such a great interaction with that mannequin. It's it's obviously the curriculum that's developed, and practicing and working through any challenges that the team is having, building teamwork, et cetera. And so I think that certainly you can work with very limited resources and still do sim training. And as far as collaboration, I probably can speak for both Carol and I. We'd be more than happy to collaborate and to help as much as we can, as you're developing any type of program there.
Yeah, and just one quick thing. I know we're short on time, but just for grants, I would say, UCSF has grants. They're mainly like intramural or internal grants, but I would say don't forget about your private companies. Like some of the sim companies like Laerdal, they offer grants too. So, and then again, I agree with Nick, don't go for the bells and whistles because that oftentimes doesn't work where you're going anyway. But like I would say, they offer grants. So you can go to companies and things like that and you can get sometimes enough just to buy your basic stuff if you find it helpful.
Great, thank you. For those that need to log off, feel free. But Lahini, I was just curious if you can